morning, everybody. Welcome to our virtual Walk with the Future Doc. It's always nice to see everybody walking, especially in the cold weather. It's very motivating to get out and walk a little more. My name is Lauren, and I'm a third-year medical student at WVU. So I just wanted to introduce myself and give everyone a quick overview of what to expect over the next hour as we walk together virtually. So first, we're going to be hearing from Dr. Haggerty about the topic of obesity as a disease. And then as we walk together, she'll be able to answer questions. Everyone should have received a little pop-up notification just to consent to the recording of this walk. And only the audio portion will be made available publicly on our YouTube channel, which is WVU Walk with the Future Doc. And then our Facebook page also is WVU Walk with the Future Doc, and that's the best place to look for updates about future walks that we'll be having. So thank you all for joining us today. Now I'd like to introduce everyone to Dr. Haggerty, who is a family medicine physician at WVU Medicine's Medical Weight Management Clinic in Morgantown. So I will let her start speaking about the topic of obesity as a disease.
Hi guys, I just was trying to make sure I wasn't muted. So I hope not to ramble. I have a lot of things to say about this, so I'll try to keep it short and simple to kind of introduce the topic. And then in the future, if we want to go farther into the topic, we can. So it is really cold out here, sorry guys. So I practiced primary care for about 13 years before I got boarded in obesity medicine. And in those years, I had multiple patients come into my clinic and bring up weight, and I would talk to them pretty shortly about diet and exercise. And I often, if a patient asked about things like medications, I often would tell them I don't do medicines for weight loss. And then when I went into obesity medicine training and really got a backing on what factors go into obesity, I realized that there's a lot more to it. I was actually kind of bothered that I would talk to patients about high blood pressure or diabetes as a disease. I would tell them, in patient terms, that there's hormone causes to this. There's lifestyle causes to this too, but there's hormone causes. We can help treat it through multiple ways. We can help treat it through lifestyle changes, but we can also use medicines that help with a lot of the hormone and neurotransmitter and different reasons why, or things we can do to treat it. And I'm still a little bothered myself about why was I okay with that? Why was I okay to say high blood pressure is a disease, has all these factors to it. Diabetes is a disease, has all these factors to it. And then for obesity, I was quick to say, well, that's kind of your fault. You need to move more. You need to eat less. And that's the treatment of it. So I'm going to go out of Zoom a little bit. So tell me if you can't hear me. Because I want to read the definition of obesity as a disease. So whenever in 2013, I believe it was, the American Medical Association declared obesity as a disease. It has remained still an argument since that time, or a discussion. Maybe argument's too hard of a term. But the definition given by the Obesity Medicine Association in the obesity algorithm, it's long. It says, chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So that's kind of I feel like that's kind of a long definition that has a lot of words that I don't know that I fully understand. I don't expect everybody to fully understand. But when you get into obesity, we think of treating it through four pillars, and those four pillars are defined by the Obesity Medicine Association. So, nutrition, movement, behavioral change, and medical. And how I like to think about it is all of those pillars relate to one another. And when I'm treating a patient, the more things I could do, the more I could do to hit each of the pillars, the more effective I can be. And so I talk with them about that. Um, so, still, when you're treating obesity, I don't want anything I say to take away that nutrition and movement is part of it. But I tie nutrition and movement back towards a lot of the endocrine and hormone reasons for obesity. So I'm going to start with two hormones related to obesity today to kind of give a jump start on our understanding that there's more to obesity than just movement and nutrition. We have to think about those other two pillars. So the two I'm going to talk about are ghrelin. So ghrelin hormone, we're going to call it like grow hormone, but it's called ghrelin. I think of the G going with grow, growl. It's one that makes us want to eat, makes us hungry. And then the second hormone we'll talk about is leptin. And leptin is put out by our fat cells. The best way I can describe it is it's the hormone that's telling our brain that we're good, we're satiated, we have enough food, and we have enough stores. So we can survive oncoming famine if we need to. But we don't often have famine now. So whenever you think of a patient with obesity, I have a lot of people tell me now, I can do your job. I could tell people just quit eating, which is fingernails on the blackboard to me. Because if you have a patient that has higher fat stores to fat cells, putting out extra leptin, telling their brain they're satiated, the brain starts ignoring that signal at a time. So it gets that signal a little too much and it starts ignoring it, kind of like our body will ignore or can't see insulin in the setting of prediabetes or diabetes. So the patients aren't getting as much of a you're good, you're satiated signal. Then the other one, the ghrelin, the grow one, it's put out by our stomach. So when our stomach is contracted, no food is in it, it's small, then your body puts out that ghrelin. That ghrelin then tells your brain, your stomach's empty, you're hungry. Well, you eat a meal and that ghrelin, your stomach gets filled up a little bit. And that ghrelin then tells your body, you got food, you're not hungry anymore. It doesn't tell you you're full. It's a leptin side, but it tells you that you're not hungry anymore. The problem is if a patient diets, so a patient brings their weight down, that hormone works a little less in the signal going away after a meal. And then over time, it stays that way. So the ghrelin's telling us we're hungry. We eat a meal. Ghrelin goes down. We're not as hungry anymore. But after a diet, sometimes, well, not sometimes, but they've found this in research, that ghrelin doesn't go as far down after a meal. And what that means is that we keep a little more of that hunger signal, a little more of that grow, growl, hunger. So when somebody loses weight through lifestyle changes, it's hard to remember, but sometimes they are more hungry. And that's our body's mechanism of seeing that their weight's gone down. Therefore, the body might see that as starvation. And it'll try to get the patient or the person through these hormones to then eat more and have that hormone higher even after a meal so that they eat more and therefore get back to their safe point, which is their highest weight. So those are two of the hormones that we're often dealing with in obesity medicine. And those affect our nutrition, so our food intake. So whenever I'm as a physician telling a patient to diet, I have to keep in mind that there's other forces as we're telling them to eat a different way. There's other forces telling their body subconsciously to do something different. So when ghrelin stimulates the pathway in our brain that tells us to grow, to eat, growl, stomach's growling, it also does a mechanism that tells their body to seek out food, right? So not only are you hungry, but subconsciously you're getting the signal to seek out food. So we're asking the patients to go against a subconscious hormone behavior. And that's why we have to think about all four pillars, not the two pillars, not just nutrition and movement, but also think about how their body is responding to obesity as they move forward. How long did I go there? I could go on for a while. Um, the other thing I want to say was there's a research study um, that came out where they looked at these hormones after giving somebody a very low calorie diet. So it's about 900 calories. They gave them that diet for 10 weeks. At the end of the 10 weeks, these hormones changed in a way to try to bring the patient's weight back up to that set point, that safe point. Another way I think about this, it can go either way. So if I have a patient or I go on a cruise, which I wouldn't be doing right now, but if I went on a cruise and gorged myself, ate all the things, all the rich things, and came home 5 to 10 pounds heavier, the hormones are also going to try to return me to that weight set point also. And as long as I go back to my normal diet that I was doing at home, the hormones will help me get back. So a lot of people say, they came back 5, 10 pounds heavier. And then after a week or two, they went back to their normal weight. They were able to get it off. And a lot of that mechanism is also the hormone mechanism doing it. Um, the other thing I think about with it is that all four of the pillars work together. So, an example I give a lot of times, and I know a lot of the students on this call know the difference of different nutrition. But if I gave somebody an apple and I gave somebody 100-calorie pack of, I never know what those packs are, but let's say it's like 100-calorie pack of Chips Ahoy or Cheez-It packs. And so both things are about 100 calories, right? But there's something inherently different. All of us can say one of these two things is healthier. We know the apple's healthier. But when you start looking at the reason behind that, there's a lot of reasons that I know Kathy could go into from the nutrition side. But when I simplify it down for my own self, without being an RD, it's the fiber in the apple. So that fiber decreases or slows how the sugar from the apple is taken into our body. When we slow that sugar being brought into the body, that's often where a hormone response takes over. So our body then has insulin spikes to help with sugar. And if you get a low and slow sugar intake, your insulin does a low and slow bump up. And you can use that sugar a little easier in things like muscles. But if you have a fast bump up of your sugar, you're going to get a fast bump up of your insulin. Insulin, again, another hormone. I think of it as a storage hormone in our body. Your body can't handle that sugar being really high. So that insulin hormone then helps you store away that sugar that went up fast and high. So it has to store it fast. And you can't use it in your muscles as fast. So it ends up storing it into fat cells more often. Other way I think of it, the other pillar. So we'll talk about one of all three pillars. So movement, exercise. exercise helps in many, many ways. But in that example, exercise can help us use that sugar into muscles instead of use that sugar into fat cells. So when the insulin's trying to put that sugar away, again, a hormone trying to put the sugar away, it's trying to put it away into those muscles that you're using. So we see people when they exercise have improved blood sugar control and have improved weight. So a lot of times we see weight maintenance with exercise in normal, 150 minutes a week, 250 minutes a week type exercise. Now, the third pillar in that same line of hormone thinking, so we often talk about slowing down eating. So somebody eats fast, where's some methods to slow them down? So you could slow down eating. One way that I talk with patients is to put their fork down between each bite. So the fork has to go down on the table, hopefully triggering that you should think about that bite. But then a lot of people, I also talk to them about taking a drink of water too. So put the fork down, get a drink of water, the next bite. I do that partially because we're all dehydrated all the time. But if we can slow down the body's intake of the food, one, might help with that sugar bump, but two, it can help our body get the signal of these hormones to the brain to help stimulate either the stop eating pathway in that situation or the you should eat more if they weren't eating. But in that situation, get the hormones to the brain that says, we're good, our stomach's full, we're not hungry anymore, and we've had a meal. And there's other hormones in that. So the ghrelin's in the stomach, and so we're getting the stop eating. But there's other hormones in our bowels that also tell us we're satiated, that are stimulated. It takes time for that hormone to be stimulated and sent to the brain. So when you think about all four pillars work in conjunction with each other. Now, hormone pillar does too. So depending on which pathway you stimulate in the brain, stop eating or you're full, you're not hungry anymore, I guess is a better way. So stop eating or hunger pathway. Those also subconsciously change our movement. They change our food seeking behaviors, things like that. Another thing we think about with hormones, so in the bowel, a lot of the bacteria there they think have neuroendocrine effects. So as they break down food, it goes to our brain and tells our brain different signals about our eating pattern. I think I'll stop there and maybe we could talk through some questions. And if Dr. Davidson or Kathy Shaw want to jump in if I said anything backwards, I don't think I did, but if I did, they are welcome to jump in too.
Okay, awesome. Thank you so much, Dr. Haggerty. If anybody has any questions, you can send them in the chat. You can send them to everybody, send the question to everybody, or you can send it directly to me. My name is Mia. Or you can unmute yourself and ask your question out loud. So we have a lot of culinary medicine students here on the call today. So welcome, med students, and a few physicians as well to answer some questions. I'll start you off with a question, Dr. Haggerty.
Wonderful.
What inspired you to get certified in obesity medicine?
Yeah, so I wish I could say that was because I was seeing a problem in clinic. The honest answer is that in clinic, I was still sticking on my brain of I think it's a very stigmatized way of looking at obesity. It's just diet and exercise. That's it. I wasn't thinking about the endocrine side. What really stimulated it was my husband. You would think that I would recognize this, but my husband had an infection on his finger. And after seeing 3 doctors, I finally asked that he have an A1C drawn. That A1C was 11.8. And we had no clue. We didn't have any clue that was going on. So then I had to, well, first I told him, And that day he sat around and didn't do anything and stayed home sick from work. And then I came home from work and I was pretty angry with him that he hadn't looked up anything. It's not my husband's style not to look up anything. The next day I came home and he told me all the information about diabetes. He probably spit it back to me in a more understandable manner than I ever learned it in medicine. It was kind of silly. But from that point on, our household completely changed our lifestyle. Um, and specifically, we controlled his diabetes, one with metformin, and the second thing was with diet. And so over the next year, we did, for our family, I'm not pushing any one diet, for our family, this worked. We went into a low calorie or a low carb diet. And going through that process with him was difficult. And what I think was happening was his sugar would come down like from 480 to 450, and his body would see that as a low. And what was happening was then his body was creating, the liver was creating sugar and it would bump up. And so his pattern of bringing his sugar down to normal, it took about 1 to 2 months and it looked like a sawtooth pattern. And that was eye-opening to me because I thought about how many patients I had diagnosed with diabetes and they didn't have a physician sitting next to them in the morning telling them, I think we should stay the course even though your sugar bumped up. I think we should do this. They didn't have a physician doing that. And the other thing was, it was understanding those hormones that helped me understand exactly what was going on with that sawtooth pattern. Because I think if I hadn't been there, he would have been like, well, this isn't working, and stopped the lifestyle change. Now, when I say that, we're about 2.5 years into this lifestyle change, so it's pretty much our normal now. But over that year, he ended up losing 100 pounds. And it was a lot of learning the hormones behind it. And in that time frame, I also went to obesity medicine training because it was fascinating going through the process with him. So that was the reasoning behind it. And it was that led me to believe that I could have been treating my patients a lot different and maybe with a lot more compassion, and also understanding how difficult it was what they were going through when I was diagnosing diabetes and obesity in that time.
Well, thank you so
Dr.
much for
Haggerty,
sharing that.
Yeah.
I have a question.
What's
Can you
up?
hear me?
Yes.
I've lost 75 pounds in the last year and a half. And you
Awesome.
said earlier that that your body is trying to get back to a steady state, and I think you actually said it's highest. And so that was like a flag. I was like, what? If my body's
Yes.
trying to get back to that weight, like what is the steady state it's really trying to get back to, and how do I maintain to keep it happy so that it's trying to get back to a reasonable steady state?
Yeah, so when you think of obesity, obesity is a chronic relapsing condition. It's something that when you have obesity, can you all hear me still? Can you all hear me?
Yes.
Okay. When you have your high weight, they think is set at like a weight set point, and those hormones see anything below that kind of as a starvation point. Now, like I said, with those hormones, so all 4 pillars are interconnected, right? So I think of it as like, can I give a medicine to help somebody lose weight? Yes. Can I give a medicine that will help change their diet? Sure. In some ways, yes. It could definitely help in many ways. But is that the only thing I can do? No. So I think what we have to think about whenever we're treating patients and have lost to that 75, one, understanding that hormones lost 75 pounds, understanding those hormones that affect that is important, but also doing the lifestyle changes, the behavioral changes, they all tie into those hormone changes too. And so I use that a lot to help explain things like plateaus to patients. So a plateau can be really frustrating But if you understand why the plateau is there, your body's kind of fighting against what you're doing, and staying the course can help. But I think the most important thing is having those healthy lifestyle changes on board, gaining those as you're going through the process. And then we can help also from the hormone side with medicines, but those lifestyle changes are also helping with those hormones. So it's not a detrimental thing. I don't want anyone to take it as a detrimental thing. People can lose weight and maintain that loss for long term. It's just something that I think you always have to be vigilant about. After people.
Did we lose her?
It's part of the healthy lifestyle, but it's not necessarily what's creating the weight loss, right? It's playing a role it's one of the 4 pillars playing a role in. But if I can get a patient exercising before they get to maintenance and make that a normal part of a healthy lifestyle, then that can be really helpful and protective towards weight regain once they're in that maintenance phase. Does that help with that question?
Yes, totally. Thank you.
All right, Dr. Haggerty, are you able to see the chat?
Oh, yeah, I probably can. Let me pull it up.
Okay.
Okay, yes. Why does the package insert say these meds are short-term meds when we know that it takes more than the short 3 months? So, and if Dr. Davidson has better answer than me, a lot of it is because of how long the studies were with those medicines. So studies for, like, let's say Saxenda. So Saxenda is working, it's a GLP-1 agonist, and I know that's not a term all of you all know, but let's just call GLP-1. It's a hormone put out by our small bowel, usually I think in relation to the breakdown of carbohydrates. GLP-1 works in 3 ways. It decreases our sugar and insulin. It's a diabetes medicines or GLP-1s. It also, Beck's food kind of slows it down from leaving the stomach and going into the small bowel. So you get a little more of that stomach stretch and your ghrelin stays lower. So you aren't getting as much of a you're hungry signal. It also goes to the brain and stimulates that satiated pathway. So it's getting that class of meds is getting a lot of press right now because there's a few of them. There's Saxenda. But in diabetes, it's also called Victoza. So if you look at studies related to weight gain, a lot of them were done with about a 3-month time frame. But if you look at studies related to diabetes, there's longer term data on it. So when they get that approval, they're getting the approval for the amount of time that often they're studied, and not necessarily the amount of time that's safe to use them. So many of these meds, if we're using a medicine, many of them we use long term, especially if the patient's having benefit from them. And it just has to do with those studies, I think, mostly.
Yeah, so I can jump in a little bit here too. I think it also has to do with weight bias. I mean, people used to say this is just a temporary fix. You know, we'll get you to lose weight, and then you'll be fixed, you'll be cured. And we know that that's not really true. We know that this is a long-term problem, and it's just the philosophy, I think, of managing weight has changed over time. And the meds, the phentermine, that's the one that you're talking about, that's 3 months limited, was really just, it was FDA approved way before we've changed our philosophy. And I mean, you know how it is, once the drug gets FDA approved, it's hard to go back in and change it because there's not really a financial motivation for the companies to go in and try to get the FDA approval changed. So what we have to do is advocate that these medications are safe to use long-term and effective and don't cause adverse health problems, and that the philosophy is this is a chronic disease that needs long-term treatment. And so I think if we advocate for that and we kind of change what's considered to be the standard of care, then physicians feel a little bit more comfortable prescribing it long term. There's one state I know of in Ohio
Yes.
where it's actually illegal according or illegal or against the medical board of medicine in Ohio to prescribe phentermine for longer than 3 months, and you can get in a lot of trouble, lose your license, that kind of thing. And so there's a lot of advocacy work going on in Ohio to try to educate about the new philosophy of obesity as a disease. And since it's a chronic disease, they should actually take their medicine more indefinitely than just a 3-month temporary thing. So
You too. Yeah, I think that weight bias thing is it's still so strong in the medical community and outside. There's a recent, I think, article that came out that wonders if the stigma and bias to obesity is actually more detrimental to health than obesity. And I think that that's one of the factors that went into it, is the fact that a lot of people won't treat obesity past the 2 pillars. And it is steeped in bias.
yeah,
I think
you don't withhold someone's treatment for diabetes type 2
Right.
while telling them to lose weight. You go ahead and treat them, and of course you encourage them to lose weight, but you treat at the same time. And it's really the same thing for treating obesity. Why are we withholding treatment that can help them be more successful with sticking to their lifestyle changes?
And
And then
so
I don't-
in line with that, my husband and the diabetes, his A1C was 11.8. We started the metformin. We started the lifestyle change. His next A1C was 5.6. His next A1C was 5.0. We stopped the metformin at that time, and he has been off of it for a year and a half now, with his A1C stabilized out at 5.4 with lifestyle change. So we treated him on the front end, and now it's lifestyle change, but we think of obesity so backwards from that.
And I'm not sure which is the cause and which is the effect, but obesity traditionally has not been taught in medical school as a disease. So I'm not sure if that's the reason we're not seeing it as a disease, or if the bias is causing it to not be part of our medical education.
Well, I think there's so much steeped into the calories in, calories out thought process, which is, I feel, steeped in the stigma side of it too. I don't think these people are thinking of being, thinking of as stigma. Or I think there's a lot of very kind people. But when you think a lot of the students on right now, I know, are from culinary medicine. And my example of a apple and 100-calorie pack being inherently different, we know that there's more than what the calories are. We know that there's a whole lot more than what the calories are. So I don't like the thought process of calories in, calories out. I do think it's important to eat healthy calories, but what that means can be very different based on what style of food you're eating.
Dr. Haggerty, there's another question in the chat. I'll go ahead and read it out loud to you.
Yes, thank you.
So the question is, do you test on your patients to monitor their levels of leptin and ghrelin? If so, what is that process like?
That's a really good question. And no, we don't. So leptin, the importance about leptin. So when it was found, I want to say it was probably in the 90s, maybe 80s, that it was probably more 90s, that the fat cells were actually making a hormone, and that hormone told our brain that we were satiated. So the scientists, very excited at that, because maybe we could just give the patients leptin and they would feel satiated and not want to eat so much. So they tried that, and it didn't work. And that gets at that thought process of the same thing like pre-diabetes and diabetes. The brain stops listening to the leptin a little bit. That signal doesn't matter as much to the brain. So when they gave people leptin, it didn't make any change because the brain was already ignoring it. So you're just getting more for the brain to ignore. So we don't measure that, and we don't treat with that, except in kids if they have what's called a leptin deficiency. So in kids, they can be born with a leptin deficiency. It's really important. I mean, interesting, if you go to like Google Scholar and do a search for leptin deficiency in children, you'll see some pretty stark images of these kids that lose incredible amounts of weight after they're given leptin. But when you think about that, they're not getting that satiated hormone. Their body's not ignoring it. They just don't have it. It's like type 1 diabetes. They plain out don't have insulin. These kids plain out don't have leptin. So if you give them leptin and give them that signal, it can be a really strong signal. But that's only in the setting of leptin deficiency. So they aren't getting it. Now, ghrelin, no, that too. We don't measure it. It is a really important hormone in the effects of bariatric surgery, but wouldn't change. At this time, we don't have anything that would do to change our treatment plan.
When you make that comparison, it kind of makes you think, is using insulin as standard of care for type 2 diabetes appropriate?
Right. Yeah, the insulin I think of as weight gainer. It's a hard one because some people need it. I mean, in type 2 diabetes, of course, in type 1 diabetes, they need it. We don't think of it in that weight gain potential as much there because they're getting what the body would baseline be making. In type 2 diabetes, when we're treating that with insulin, it can be a weight gainer, but taking that away can also be dangerous because we don't want their sugars running high. But we can also start thinking about some of the other diabetes medicines like Victoza and things like that that might be weight negative or weight neutral, and see if we can get those sugars under a little better control, help with that weight loss, which would then help with the disease process, the hormone disease process.
We just need insurance to keep up with us.
Yes, if somebody could get insurance to cover this stuff, Dr. Davison's probably gotten us the most bang for a buck in our state with her advocacy. But yeah, that's the hard part, is the cost of some of them. Were there other questions in that chat? I can look there. This makes us feel that we are going against standard of care. Oh, the 3 months. Kathy had to get off. Okay, National Weight Loss Registry says that regular is most important in maintenance, the most important time to exercise. I think what that's probably getting at is how much exercise for weight maintenance, maybe. So I think of getting a patient to 150 minutes a week as being something that's helpful for weight maintenance when they get into the maintenance stage. And of course, that's getting at that hormone response to exercise, right? And then also 2 times a week of doing weight training would be what I would see as optimal weight maintenance exercise. I do not like for patients to try to lose their weight only through exercise. You need a lot of hours per day. I think it's between 2 and 3 per day to lose weight with exercise alone. So I usually talk to patients about it more as a, it's a helpful thing for those hormones. Amazing for brain health, amazing, for mental health, amazing for cardiovascular health, and then great for weight maintenance.
I think you're right about the 2 to 3 hours a day. I recently saw an article that at least 300 minutes a week of exercise, and that's at least, is required for weight loss with exercise. But there's also the adage, you can't fight your fork. Can't run away from it.
So I think of it as one pillar of the 4. It's one pillar. But then also when I'm talking with patients that might have like joint, their knees hurt, they really struggle with exercise. It's also one of 4 pillars. We have 3 others we can work on, and we'll talk through the exercise as we go along. But I don't think they're not able to lose weight because they're struggling with movement.
All right. Are there any more questions? If not, we'll have Dr. Haggerty wrap it up, and then we have some recipes to share today.
Oh, that's right. I forgot about the
Yes.
Valentine's Day. Yes. Well, I just, if anyone has any more questions for me, I think the biggest takeaway of this is to remember that obesity is a chronic relapsing disease. It's not a failure of lifestyle, because all four of those pillars intertwine. They're all important in their own right, and they all affect each other. And so when you're taking care of patients, I think it's important to remember that it's not just the failure of their diet, the failure of their exercise. It's more than that.
Awesome. Well, thank you so much, Dr. Haggerty, for talking to us about obesity today. I want to introduce a classmate of mine named Kat Hatchbeck, and Kat is in the culinary and lifestyle medicine track with me. And since February is American Heart Month, Kat has some recipes that she's going to share in the chat that are heart healthy recipes. So I'll let her go ahead and talk about what she's sharing. So you should be able to open the chat up and download these.
Hi, I'm Kat. I just finished my walk and had to come back to the computer to be able to share these recipes with you all. So it is American Heart Month, and we'll be sharing a lasagna recipe, a chicken noodle soup recipe, and also some chicken kebabs, which looked just fun. And so I'm gonna throw those into the chat, and it'll give me a second, and it might take a minute to download. But thanks for the great talk. It was awesome.
Hey, Mia, could we put the recipes on the Facebook page too?
Yes, I was just going to say that. So if
Okay.
you can't
Yeah, I can
download
do
them
that.
today, yes, thank you, Meg. So if you can't download them from your phone or whatever device you're using right now, we'll post them to the Facebook page sometime soon. While you have the chat open, we are trying to see how far this program reaches. So thank you for joining us today. If you wouldn't mind typing in the chat who you are and where you're walking from, we'd love to see you or know who you are and hopefully see you again. Our next walk will be in 2 weeks, and I'm very excited for this talk. So information about that coming soon to our Facebook page. So thanks so much, everyone, for walking with us in the cold today. I hope you enjoy a great Valentine's Day weekend and you can use some of these recipes.